You have stopped taking the stairs. You sit in the one chair that does not make it worse. The MRI was 2 years ago. The first injection helped, the fourth did not. Your world contracted to the recliner in the kitchen. I am an interventional pain physician, and this is what I want you to know. I practice interventional pain management here in St. Louis. Here is what is missing from your chart. There is a column for morphine equivalents. There is none for how long you can stand, how far you walked this week, or how many things you said no to. Fear and avoidance are among the best documented correlates of disability in chronic pain, and nobody measured yours. Not because it is unmeasurable. The questionnaire takes 4 minutes, but because no procedure attaches to the answer. Here's the finding nobody wrote down. Whatever your disc is doing, a behavior set has been accumulating alongside it. Every movement, outing, and obligation you deleted because you associate it with a flare. The prospective data are consistent that fear and avoidance track disability better than imaging does. Be exact. Strong association, plausible mechanism, not a proven cause in you, but nobody has offered to address it, and it is addressable by name: acceptance and commitment therapy. Before I ask you to do behavioral work, you are owed the mechanism and the edges of it, because here the confident version and the honest version are not the same version. Acute pain is a report. Nociceptors fire, tissue heals, the report stops. Pain past that window is different. Amplified dorsal horn signaling, weakened descending inhibition from the periaqueductal gray and rostral ventromedial medulla, threat learning across the amygdala, insula, and cingulate. The nervous system is not reporting damage. It is predicting it. That model comes from human imaging and animal work. It is the leading framework. It is not confirmed human physiology, and reciting it as fact is overselling. What is not in dispute is narrower. Disability tracks imaging poorly. A sensation arrives. It is read as damage. You guard, you cancel. Guarding produces deconditioning. Deconditioning shrinks tolerance, and the interpretation is confirmed. In that model, avoidance is an excellent short-term analgesic, and the cohort suggests a costly long-term one. You do not get to invoke central processing until you have earned it. New weakness, bowel or bladder change, fever, unexplained weight loss, night pain, a cancer history, that is imaging and laboratory work today, not psychology. The differential is resolved with anatomy, not adjectives. No history item and no examination maneuver reliably identifies the facet joints as the pain generator. Maas and colleagues, European Journal of Pain, 2017, put the sensitivity of physical examination anywhere from 11 to 100%. So the answer is a low-volume medial branch block under live fluoroscopy at the superior articular process, transverse process junction, with the percentage of pain relieved during the anesthetic window as the only readout, and false positives on a single block run 27 to 47%. So one positive block is a hypothesis, not a diagnosis. Burning numbness in both feet is a polyneuropathy until proven otherwise. The neurology practice parameter names the highest yield tests: a blood glucose, then a glucose tolerance test, if that glucose is not diabetic, a B12 with its metabolites, methylmalonic acid, since a normal B12 can be functionally deficient, and a serum protein immunofixation electrophoresis to catch a paraprotein. The fasting insulin I add is my practice, not the guideline. A treatable driver or a myeloma hiding under a psychological label is a failure I refuse to commit. The order is the whole argument. Behavioral work goes third, never first. A program handed to a patient whose diagnosis is unfinished is not treatment. It is a way of closing the file. First, the structural question gets answered and named, with a block that answers a question rather than filling a slot. Second, the metabolic question, because a starved nerve does not respond to psychological flexibility. Be exact about what is proven there. Ketogenic nutrition, specialized pro-resolving mediators, and photobiomodulation between 660 and 850 nanometers are investigational adjuncts, not standard of care. I will say so in the room rather than let you infer it from a brochure. Only then, third, does anyone say the word acceptance to you. The full model has 6 processes, In pain programs, four do most of the work. Acceptance. You stop fighting a sensation you cannot switch off. Diffusion. You watch the thought that your spine is disintegrating instead of obeying it. Values. You name what pain has taken. The grandchild, the workbench, the mile walk. Committed action. You graduate activity toward those on your schedule. A licensed pain-trained psychologist delivers it across 6 to 12 sessions, never inside a procedure visit. This is for adults past 3 months of pain, 3 months, not a year, whose workup has cleared deficit, infection, fracture, and malignancy, and whose lives have narrowed around avoidance. The higher your avoidance, the more there is here for you. The trials measured benefit over 3 to 12 months. That is the honest horizon. If your pain is 6 weeks old or the workup unfinished, you are not a candidate today. The largest synthesis is a 3-level meta-analysis by Lay and colleagues, Behavior Research and Therapy, 2023, 33 randomized trials, 2,293 patients. Post-treatment hedges G, 0.44 pain intensity, 0.59 physical function, 0.43 depression and anxiety, real and modest. Longer follow-up correlated with smaller effects for pain intensity and for physical function. Pain intensity falls from 0.44 to 0.34, while the mood outcomes held steady. And face-to-face beat internet-delivered ACT on the physical outcomes. The app is not the same product. For fibromyalgia, Eastwood and Godfrey, British Journal of Pain, 2024, 6 trials, 384 patients. Pain acceptance improved substantially. Fibromyalgia, impact improved too, but imprecisely. That confidence interval very nearly touches no effect. Now the hardest number. The 2020 Cochrane review by Williams and colleagues compared ACT not against a waiting list, but against an active comparator. 5 studies, 443 patients. Pain, disability, and distress all favored ACT numerically, and not one reached statistical significance. Every confidence interval crossed 0. That evidence was graded very low certainty, and adverse events across this literature are inadequately reported, so safety is not established either. Against doing nothing, ACT beats nothing. Against another active treatment delivered with equal attention, it has not been shown to win. Very low certainty does not mean it fails. It means the trials were too small, too unblinded, and too self-reported to tell us. The risks are not 0. When you stop avoiding, distress rises before it falls, and grief or old trauma can surface. With a post-traumatic stress diagnosis, trauma-focused treatment belongs alongside or before this work. Graded activity often brings a short-term flare. Mood can worsen, that warrants a phone call. Attrition in the fibromyalgia trials ran near 20%, under that mark in 4 of 6 studies. 1 patient in 5 did not finish and assumed they did worse than those who stayed. An ACT changes nothing structural. A torn annulus is still torn. What I am about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. The numbers in it are illustrative. They show the shape of a course that goes well, not an average, and not a schedule you should hold yourself to. An adult with axial low back pain past 4 years. 2 surgical consultations, both declined, medial branch blocks that were diagnostically informative, with real but finite relief. The activity log was nearly empty. The first 6 weeks of behavioral work were worse, not better. The values work surfaced grief. There was a flare in week 5 that felt like proof the whole thing was a mistake. It was not proof, it was week 5. In a course that goes well, the graded walk is measured in minutes by around the 4th month, and in fractions of a mile by the 9th. A meaningful number never get there, and I will not hide them from you. What changes is how much gets done anyway, and some of that gain attenuates. That is not a cure, and I am not offering you one. It is function returned, purchased with work. If nobody has handed you a diagnosis you can name, come get one. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. The full discussion lives at painmd.tv. Get the diagnosis first, then decide whether you want to do the work. I cannot promise you the mile. I can promise that nobody will measure what you have lost unless you make them. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.